Good evening, everyone. I am going to speak upon the role of atezolizumab in the first-line treatment of non-small cell lung carcinoma. We do realize that lung cancer is an extremely evolving landscape, and we currently have got a lot of options available now for the treatment of the disease. Now, we would be covering the following topics. We would start with covering the disease background, then the evolving landscape of lung cancer treatment, then these three studies, IM Power 110, IM Power 150, IM Power 130 study, right? So if we start with the introduction of non-small cell lung cancer. So non-small cell lung cancer is actually a slow-growing tumor with very varying initial overall response rate. Now that depends upon the driver mutation as well as the targeted therapy. Another thing to realize is that it constitutes about 80 to 85% of all lung cancers. The median age of presentation is 70 years, and around 15% of the patients are never smokers. Now, in the patients who present with the disease, around 55% of the patients at diagnosis have metastasis, right? And over the period of the past few decades, the targeted agents have improved the survival rates also, especially in the patients with the driver mutations.
Dr. Raghav, you have muted yourself again.
Sir, actually, my slide, I'm not able to toggle through it.
Can I share from my side, Raghav sir?
Yeah, so I think, yeah, now it's working. So if we talk about the evolving landscape of the lung cancer, in 1980s, the only options that were available to us were chemotherapy. At that time, basic distinction among between the non-small cell and the small cell lung carcinoma was also not available with terms of chemotherapy. Gradually, as we reached the 90s, based upon the histological subtype, the chemotherapeutic agents were also subdivided. And gradually in 2000s, we discovered EGFR cross on all the targeted mutations, and targeted therapy was developed. And recently, in the past 10 years, we have now developed checkpoint inhibition and are now using cancer immunotherapy, which has actually revolutionized the treatment of lung cancer. So another thing to realize is that we do have a lot of actionable markers. Now, if you see the subdivision here, among all the cases of lung cancer, 29% were found to have KRAS mutations, which have only recently become targetable. Then we have got EGFR mutations in 11% of the patients, and ALK mutations in 5% of the patients. In a significant proportion of the patients, that is 35%, there is no significant actionable biomarker, right? As of now, it has not been discovered. And with the advent of targeted therapies, there has been a significant change in the overall survival. So with the targeted therapy, we are able to achieve an overall survival of around 32 months. With just the cytotoxic therapy, it's only around 12.7 months. So as you can see that the advent of targeted therapy has led to the almost, there is 19 months of OS benefit. So now we will be talking about the role of atezolizumab. The following trials, IM Power 110, 130, and 150 will be covering. The first trial to cover is IM Power 110, which actually compares atezolizumab monotherapy with the conventional chemotherapy agents in PD-L1 selected chemotherapy naive patients. So if we look at the trial, it was a phase 3 multi-center study. The inclusion criteria was all cases of stage 4 non-squamous or squamous NSCLC who were chemotherapy naive, EGFR cross negative. PD-L1 calculation was also done on all the patients. The platform used was Vendana SP142 assay, and the stratification was done on the basis of sex, the performance status, histology, as well as the PD-L1 IHC expression. So the patients were divided into two groups, 1:1 ratio. The first group was given atezolizumab at 1200 mg Q3 weekly. The second group in non-squamous patients, carboplatin or cisplatin plus pemetrexed was given, followed by pemetrexed maintenance. In the squamous group, platinums plus gemcitabine were used, and there was no crossover permitted in the trial. And the maintenance therapies were continued as long as there was no progression in the disease or the patient was unable to tolerate the therapy. If we talk about the prevalence of PDL1 in the two arms, PDL1 expression in the two arms, you can see here that the division was almost comparative between the two arms. The patients with high PDL1 status were around 38.6% in the atezolizumab arm and 35.4% in the chemotherapy arm. The patients with more than 5% tumor cell or infiltrating cell PDL1 expression were again 59.9% in the atezolizumab arm and 58.5% in the chemotherapy arm. Now, if we talk about the baseline characteristics, they were also well balanced between the two arms, as you can see in this table. So they were equally, almost like equitably distributed in terms of age to sex ratio, as well as the histologies that were seen. Same with regards to the performance status also. Now, if we talk about the OS benefit in this trial, so this trial, if we will see median OS benefit of around 7 months was seen in the atezolizumab arm. So the median OS was around 20 months was seen with atezolizumab, and median OS of 13 months was seen with just the chemotherapy part. Now, this benefit was practically seen over all the subgroups. Now, if we see about the progression-free survival, a clinically significant PFS benefit was seen in the atezolizumab arm. The PFS benefit of almost 3 months had been seen in the atezolizumab arm. Now, if we talk about the safety profile, now you'll notice here that the number of adverse events was obviously, as we would expect, more in the chemotherapy arm than in the immunotherapy arm. And but the number of immune-mediated adverse effects, again as expected, was more in the atezolizumab arm than in the chemotherapy arm. So if we see the overall tolerability of atezolizumab arm was better than the chemotherapy arm. Now, if we talk about the side effect profile, the most common side effects that were seen in the chemotherapy arm was anemia, nausea, neutropenia. And in comparison to the atezolizumab arm, even atezolizumab arm showed these the commonest side effects, anemia, nausea, etc. But if you see, the proportion was significantly very less in the immunotherapy arm. Conversely, in the atezolizumab arm, there was an increased amount of AST elevation, pruritus, as well as the hypothyroidism, which again are known and expected autoimmune side effects. But these were also all mostly manageable with the use of steroids. So summarizing this trial, based upon this trial with patients with PDL1 high NSCLC, atezolizumab was a promising first-line treatment option. And atezolizumab also had a favorable safety profile compared with the chemotherapy arm. And the treatment exposure in atezolizumab arm was more than the chemotherapy arm. Next, I would like to go to IM Power 150 study. So this was a phase 3 study where atezolizumab was added to chemotherapy and bevacizumab in first-line advanced non-squamous non-small cell lung carcinoma. So the key clinical questions that it addressed was whether the addition of atezolizumab to the standard of care bevacizumab plus taxane and platinum added a clinical benefit, and was there any clinical benefit if bevacizumab was replaced by atezolizumab. So the patients that were taken were stage 4 non-squamous non-small cell lung carcinoma, chemotherapy naive patients with stratification on the basis of sex, PDL1 expression, and the liver mets. Now we talk about the endpoints that we were assessing was the progression-free survival as well as the overall survival between the arms. So if we see then in this trial, the patients were divided in 1:1:1 ratio. In the first arm, it was atezolizumab plus pacli plus carbo. Second arm had 4 drugs, atezo, carbo, pacli, and bevacizumab. And third one only had bevacizumab plus chemotherapy. Respectively, the maintenance was continued with only atezolizumab in first arm, atezo plus bevacizumab in the second arm, and bevacizumab only in the third arm. It was continued till there was PD or loss of clinical benefit. Now, the rationale behind adding all these was, first of all, chemotherapy would lead to the death of the cell and release of tumor antigens. Atezolizumab, in turn, would the release of the tumor antigens would lead to triggering of the immune response. This inhibition of immune response would be suppressed by atezolizumab, and bevacizumab in turn would also inhibit VEGF-mediated suppression of the immune response. Now, if you see again, the baseline characters were well matched between the arms. Another thing to note in this trial was that patients with EGFR ALK mutation were also taken. Only those patients with EGFR ALK mutations were taken who had either progressed on first-line TKIs or were unable to tolerate TKIs. Upfront EGFR ALK mutation patients were not offered the treatment. So if we compare the two arms, then overall, if we look at the overall survival, then overall survival benefit of almost median OS benefit of almost 5 months was seen in the atezo plus bev plus chemotherapy arm. If we compare it to just the bevacizumab. Now, if you see that the median OS benefit of 4.5 months was seen, if we compare it on the basis of the PD-L1 expression, overall also in patients with PD-L1 high, the overall response rate of 69% was seen. In the B arm, that was atezo plus chemo plus bevacizumab in comparison to the bevacizumab plus chemotherapy arm. This benefit was also seen in the patients who were PD-L1 low as well as PD-L1 negative. Also, if you see, the median duration of response was higher in B arm compared to the C arm. Like the B arm would be your immuno plus chemo plus bev, and C arm would be just bevacizumab plus chemo. Now, if we compare the OS between the patients in terms of PD-L1, maximum benefit was seen in patients who were PD-L1 high. If you see, there was a OS benefit of almost 10 months in the patients who were PD-L1 high, but even in the PD-L1 negative patients, around 3 months OS benefit was obtained. Now, coming to the patients who were EGFR positive and had progressed on tyrosine kinase inhibitors, if you will see that the curves, they started separating at around 6 months, and again we could see the benefit of almost 3.5 months in the patients who were EGFR positive in the atezo plus bev plus chemotherapy arm. Now, if we talk about the OS benefit in patients with the mutations, then again the benefit of around 11 months was seen between the two arms. But this benefit was actually not very significant in arm A versus arm C. Now, overall response rate was increased by from 42 to 71% with the addition of atezolizumab to bevacizumab plus chemotherapy. The median duration of response in atezo arm was 11.1 months, and it was around 4.7 months in bevacizumab plus chemotherapy arm. Now, coming to the patients of liver metastasis, again we had a PFS benefit of almost around 3 months in the patients with liver metastasis. So this is significant as liver metastasis by itself is a significant negative prognostic factor. Now, again, the benefit was in OS was seen in arm B versus arm C. That would be atezo plus bev versus only bev plus chemo. In the arm where atezo plus chemotherapy compared with bev plus chemotherapy, the significant benefit was not seen actually in patients with liver metastasis. OS benefit again was seen in patients of liver metastasis, an OS benefit of almost 4 months was seen in arm B versus arm C. Now, the overall response rate as well as the duration of response was higher in atezo plus bev plus chemotherapy arm if we compare it only with bevacizumab plus chemotherapy arm in patients with liver metastasis. Now, if we talk about the patients with bulky disease was defined as patients having high disease burden or low disease burden. High disease burden was where you had more than 2 metastatic sites. Median here is 2 sites. So more than 2 metastatic sites was more than equal to 2 metastatic sites was taken as high disease burden, and less than 2 metastatic sites was low disease burden. This benefit was also translated in high as well as low tumor burden sites. In both the scenarios, the median OS benefit was obtained. However, in the low burden sites, the benefit was almost of just a month, the median OS benefit. But in the high burden sites, it was almost of 5 months. So now this data supports the use of atezo plus bev plus chemo as the first line in bulky disease. Now, if you see, then the degree of adverse effects was equivalent in all the arms. So in the previous study, if you remember, in the immunotherapy arm, the adverse effects were significantly lesser. But here, actually, the greater proportion of side effects is actually expected in the B arm and all the arms because chemotherapy was a part of all the arms. And if you will notice, then the immune related side effects was significantly higher in arm A and arm B in comparison to arm C. So between all these three, the high amount of adverse effects were seen. So as you can see, then IM power 150 was a positive study. It showed statistically significant improvement in the endpoints of OS as well as PFS with the addition of atezo to bev plus chemotherapy arm. And as well as if you talk about the safety profiles, then the safety profile of both the arms was almost similar. So now if we come to the, now I will come to the next study, that is IM power 130. IM power 130 was a phase 3 study where carboplatin and nab-pac, there were actually chemotherapy plus immunotherapy combination was done. The rationale used behind it was that chemotherapy again would lead to the cell death and release of tumor antigens, and the release of tumor antigens would lead to triggering of T cell activation. So the T cell deactivation caused by PDL1 would be suppressed by atezo, which in turn would create a more favorable microenvironment for action against the tumor. So again, if we talk, so we here non-squamous non-small cell lung carcinoma stage 4 patients who were chemotherapy naive were selected, and they were stratified on the basis of PDL1 expression, liver mets, and the sex. So there were two treatment arms. One was atezo plus carbo plus nab-paclitaxel. Other was the chemotherapy arm of just carboplatin plus nab-paclitaxel. The atezo plus chemo arm was followed by atezo maintenance till PD or loss of clinical benefit, and the carboplatin plus nab-paclitaxel arm was followed by pemetrexed maintenance. So in this, there was, I think, that crossover was permitted from initially from arm B to arm 8 was permitted. Later on, it was not permitted. But in spite of that, 41% patients in the control arm crossed over to atezolizumab. So even in the control arm, 59% of the patients ended up receiving chemoimmunotherapy. Now, if we talk about the baseline factors, they were again well divided between the two arms. So if we talk about the results of the study, progression-free survival, median PFS benefit of 1.5 months was seen. But at 12 months, the PFS benefit of 29.1% versus 14.1% in the chemotherapy arm was seen. So if you see that the addition of atezolizumab to the chemotherapy led to the doubling of 12-month PFS. Now, if you talk about the OS benefit, we had an OS benefit of almost 5% in the patients who were given atezo plus chemotherapy. So this was seen in spite of the fact that 59% of patients in the control arm had shifted to chemoimmunotherapy. Now, if we see, then the median OS benefit was again reproducible along all the subgroups, even among the PDL1 high, low, as well as the PDL1 negative subgroups. Now, if we talk about the overall response rate as well as the duration.
My apologies, sir. You are left with 1 minute to conclude your presentation.
So if you see the slide, then the duration of response was higher in the atezo plus platinum arm. Talking about the proportion of adverse effects, the number of adverse effects was more in the number of adverse effects was comparable between the two arms because of chemotherapy being the part of both arms, with a significant proportion of increased autoimmune side effects in the patients who were receiving atezolizumab. Now, to conclude, IM Power 130 was a positive phase 3 study which provided significant OS benefit when atezolizumab was added to carboplatin plus nab-paclitaxel. Higher overall response rate PFS benefit was seen. And one thing about this study was that in this study, again, EGFR-ALK positive patients were taken, the ones who had progressed on TKIs, but in this, the benefit was not seen in the EGFR-ALK positive patients. So with this, I would like to conclude, and I would like to thank everyone for this session. Right.